Tonight's presentation is entitled Sexually Transmitted Diseases, and it will be an update of the 2010 recommendations by the CDC. Our distinguished presenter tonight is Dr. Sesu Sarma. I can never say her name correctly. Dr. Sarma is an associate professor in the Department of Obstetrics and Gynecology at Morehouse School of Medicine. She is a reproductive health consultant for women with HIV at the Fulton County Ryan White program. Over the years, she has been involved in clinical research and published several papers on reproductive health issues. As a member of the Speakers Bureau for the Emory Regional Training Center, Dr. Sarma has given over 300 lectures on various reproductive health issues, including STDs and HIV. I would like to note that during tonight's presentation, we will not have a specific section for question and answer. However, as your questions and or comments arise, please feel free to type them in the Q&A box that you should see at the bottom of your screen and click submit. And as she sees them come through, she will answer them. So with all of that said, ladies and gentlemen, let's please welcome Dr. Sarma.
Thank you, Sabrina, for such a wonderful introduction. What I'm going to talk about tonight is specifically a preventive aspect of it. How to take good history, how to evaluate a patient, and how to counsel patients, and basically prevention. And I'm going to focus on several aspects of prevention of STDs. Let me see. In compliance with the American Academy of Family Physicians guidelines, I hereby declare that I do have a relationship with Chickatelli Associates. I'm on the Speakers Bureau for Chickatelli Associates, and I do many lectures for them. The objectives for today's conference are the participants at the end of the conference will have a better understanding of transmission of STDs through various sex practices. They'll be in a better position to obtain a thorough sexual history from their patients. They'll be able to educate clients more effectively about specific actions that can lead to STD and HIV transmission. They'll be able to counsel in depth about how to use protective practices more effectively, and learn the most recent CDC STD screening guidelines recommended by CDC. I will not go in detail into each individual STDs, their diagnosis and management, because of lack of time. The guidelines for the prevention and treatment of persons who have STDs or at risk for STDs were recently updated by the CDC after consultation with many professionals knowledgeable in the field that were done in April of last year, 2010. Now, by definition, what is an STD? Sexually transmitted disease, also known as sexually transmitted infection, is a term used to refer to a variety of clinical syndromes, mainly caused by pathogens that are acquired and transmitted through sexual activity. These diseases may be spread through vaginal sex, anal sex, and oral sex. It's amazing how many clients that we see do not consider oral sexual activity carrying any kind of risk for STD transmission. CDC estimates that there are about 19 million new sexually transmitted diseases that occur annually in this country. About half of these infections occur in persons between the ages of 15 to 24 years of age. One of the most common infections that we see in this country is chlamydia. There are about 2.8 million new chlamydial infections, mostly in young individuals, and about 1.6 million new genital herpes infections. Gonorrhea is common, but it is much less common than chlamydia infection. Other prevalent STDs include, as I mentioned, gonorrhea, hepatitis B, much more common than hepatitis C, HIV, human immunodeficiency virus, HPV, and syphilis. HIV used to be, back in the 1980s, it used to be a gay man's disease. That's not the case anymore. We see a lot of heterosexual transmission for HIV these days. And I work with women with HIV. It's amazing how many new HIV infections are diagnosed in women who are in stable monogamous partnerships for many, many years. That's because they don't know their status, they don't know their partner status, and partners go unrecognized. And sometimes I see women who have been married for many years, husbands died of heart attacks, and during routine testing, we test them and they test positive for HIV. They have not had any idea how long they have had it. So that's why it's important that you do routine testing. Other commonly seen, other sexually transmitted diseases that we encounter are, in addition to chlamydia and gonorrhea, herpes simplex, hepatitis, as I mentioned, HPV, syphilis, HIV, molluscum contagiosum. This is a viral infection that we see in the genital area, usually self-limiting. It is highly contagious. Scabies can be transmitted through sexual close skin contact. Pubic lice is another commonly transmitted, sexually transmitted infection. Coming to prevention. The prevention and control of STDs are based on the following 5 major strategies. Number 1 is education and counseling to prevent STD transmission. Education and counseling is very, very important for prevention of STDs. Then identification of asymptomatically infected individuals and symptomatic persons that are unlikely to seek treatment. Asymptomatic infections are extremely common. Chlamydia can go unrecognized in women for months and months. Gonorrhea can go unrecognized in women for months and months. Herpes simplex virus, an individual can have HSV infection and not have any kind of outbreaks, so you see a silent infection often. HIV is the same thing. You can have HIV infection without having any symptoms at all. So identification of asymptomatically infected individuals is important. And then there are symptomatic persons who don't come for diagnosis and treatment. So it's important that we seek these individuals, make the right diagnosis and treat them so that you treat them effectively and you prevent transmission to others. Effective diagnosis and treatment of infected persons, evaluation, counseling, and treatment of their partners. And then we talk about pre-exposure vaccination of susceptible persons. 2 of the most common infections for which we give pre-exposure vaccination is human papillomavirus and hepatitis. STD and HIV prevention counseling. The United States Prevention Services Task Force recommends high-intensity behavioral counseling for all sexually active adolescents and sexually active adults who are at increased risk for STDs and HIV. I'm going to mention this in depth a little later on. Prevention begins with changing sex behavior. As healthcare providers, we have a unique opportunity to address the problem in a manner that has a positive impact. Direct questioning without dodging, with good counseling skills which are characterized by respect, compassion, non-judgmental attitude are key to successful counseling. You have to give clear message without any ambiguity that the client understands. When you obtain sexual history, open-ended questions are more effective in evaluating the situation. Understandable language is more effective in obtaining valuable information that helps you make a diagnosis and counsel properly. There are 5 areas to be addressed in terms of prevention. These 5 P's are, number 1, get the history in terms of partners. Talk about prevention of pregnancy. I know we are talking about STDs, but when you see young women for STD counseling and treatment, you have a valuable opportunity to address their risk of pregnancy, risk of unwanted pregnancy, and provide contraception so that they will not encounter unwanted pregnancies in future. Protection from STDs, the sexual practices, and also past history of STDs. I'm going to focus on each and every one of these 5 areas. When it comes to partners, what questions to ask? The specific questions that are direct questions that CDC recommends that we ask are, do you have sex with men, women, or both? In the past 2 months, how many partners have you had sex with? In the past 12 months, how many partners have you had sex with? Is it possible that any of your sex partners in the past 12 months had sex with someone else while they were still in a relationship with you? Are you trying to get pregnant? If no, what are you doing to prevent pregnancy? How much do you know about birth control? As a gynecologist, I see a lot of girls, and when I ask women, girls, about using condoms, they tell me often, well, I have sex with only one person and we've been in a monogamous relationship. I ask her, are you trying to get pregnant? She said, oh, no, I don't want to be pregnant. Are you using any kind of birth control? No. When you don't use any birth control, it's important for girls to know that condoms can be used as a method of birth control that is effective against pregnancy prevention as well as STD prevention. Protection against STDs. What do you do to protect yourself from STDs and HIV? Do you use condoms? Do you use male condoms? Do you know about female condoms? For those who use condoms, do you use condoms for vaginal sex? Do you use condoms for oral sex? Do you use condoms for anal sex? Oftentimes in my practice, I've realized that even those girls who are, since I take care of women, those who are very particular and consistent about condom use condoms for vaginal sex, but they do not use condoms for oral sex because it is not considered, in their opinion, that oral sex carries any kind of risk in terms of STDs. And these are the statements that CDC recommends. To understand your risks, I need to understand the kind of sex you have had recently. Have you had vaginal sex, meaning penis in the vagina? Have you had anal sex, meaning penis in the rectum or anus? Do you use condoms? Always? Sometimes? Never? Have you had oral sex, which means penis in the mouth or mouth on the vagina? Do you use condoms for those acts of intercourse? What about dental dam? Are you familiar with the dental dam? Do you use condoms consistently for each act of sexual intercourse? What about for oral sex? What about for anal sex? Do you use condoms consistently with each and every partner you have had sex with? What about with your steady partner? What about with your casual partner? It's amazing how many patients you see who have more than one partner. They use condoms consistently with their steady partners, but they don't use condoms with their casual partners, or vice versa. I see women who use condoms for every act of intercourse with a casual partner, but with their steady partners, they have this false sense of security that it's their baby's mother or their steady partner, so they don't have to use it. Then I ask them, if you have more than one partner, and you have a steady partner, and then you have a casual partner with whom you use condom, what makes you think your steady partner does not have another casual partner? And what makes you think that he is not having unprotected sex with someone else? What about oral sex and STDs? It's amazing how many individuals do not consider, as I mentioned, oral sex as a way of transmitting or acquiring STDs. Let's look at oral sex and the kinds of STDs that are transmitted through oral sex. Chlamydia and oral sex. Oral sex is not considered a common cause of chlamydial infection, but it is a possibility. But we do not routinely test pharynx for chlamydia. What about gonorrhea? Gonorrhea can be passed during oral sex, either giving or receiving. Ejaculation does not have to occur for gonorrhea to be transmitted or acquired. Gonorrhea survives well in the throat, and gonorrhea throat infections from oral sex are relatively common. So it's important that clients are counseled about use of condoms during oral sex. What about herpes? Herpes can be transmitted via skin-to-skin contact, so the risk during oral sex is clear. It's important to remember that transmission for herpes can occur even if there are no visible source, and herpes can be transmitted without the couple's awareness of their infection. While the risk for HIV is considered to be low during oral sex, there have been documented cases of HIV transmission where the most likely way it was transmitted was through oral sex via semen, vaginal secretions, or blood. HIV is not transmitted via saliva, and deep kissing is usually considered a safe sexual behavior. However, there have been cases of oral sex transmission of HIV during fellatio, which is performing oral sex on a man, and cunnilingus, which is performing oral sex on a woman. What about HPV? Oral sex is considered a less common cause of HPV infection, although it has been documented. HPV is shed from the surface of the warts, and any form of direct physical contact may result in transmission. What about syphilis? Oral sex is considered an effective way to transmit syphilis, with one recent CDC study reporting that more than 13% of syphilis cases were attributed to oral sex only. Transmission usually occurs during vaginal, anal, or oral sex when these syphilitic sores or patches come in contact with slightly abraded skin or mucous membranes. What about yeast infection? There is evidence to suggest that women who have recurrent yeast infections may actually be infected by receiving oral sex from their partners. So, to summarize oral sex and STDs, if a man ejaculates during oral sex in or around the mouth of his partner, or if any ejaculate gets in his partner's eyes, it greatly increases the risk of STD infection, especially if he is infected with an STD. In many cases, an STD can be transmitted even if the penis or tongue does not go all the way into the vagina, mouth, or rectum, and even if it isn't obvious that the body fluids are exchanged. Using barrier methods, including condoms and dental dams, is the best way to make oral sex safer. If there is no dental dam, we often recommend using the saran wrap. Some educators suggest avoiding brushing teeth prior to performing oral sex, as it can cause small cuts or abrasions that could increase the risk of fluid transmission. What about anal sex and STDs? Gonorrhea, syphilis, HIV, herpes, HPV are some of the STDs more commonly transmitted through anal sex. Anal or vaginal intercourse without a condom carries a very high risk for HIV transmission. Getting penetrated without a condom by someone, in other words, receptive anal sex, who is from someone who is HIV positive, is the riskiest behavior for HIV infection. So if someone receives anal sex by someone who is HIV positive, the risk of HIV transmission is greatest for the person who is receiving anal sex. Penetrating an HIV positive person, in other words, the person who is receiving anal sex is HIV positive, but the one who is performing or penetrating is HIV negative, it is still considered risky, but it is not as risky as the receptive anal sex. Getting HIV from oral sex is possible, but quite rare. Risk of HIV transmission, the specific circumstance of a sexual assault. If someone has been assaulted, what is the risk of HIV transmission? Specific circumstance of an assault, such as bleeding, might increase risk for HIV transmission in cases involving vaginal, anal, or oral penetration. The site of exposure to the ejaculate, the viral load in the ejaculate, the presence of an STD either in the victim or the perpetrator, are there any genital lesions in the assailant or the assault victim might increase the risk for HIV. Now coming back to counseling, when we counsel about condom use, the most common questions we should ask, do you use condoms? If they say never, then you ask, why don't you use condoms? And they say sometimes. In what situations and with whom do you not use condoms? And then we need to counsel as to why it is important that they use condom for each and every act of intercourse, no matter which type of sex intercourse it is. What about past history of STDs? Have you ever had any STDs? Has any of your partners had an STD? One STD means you could have been exposed to more serious STDs. So if you had gonorrhea, chlamydia in the past, you might have been exposed to other STDs and you should be tested for them. What about HIV and hepatitis risk? Have you or your partner ever injected drugs? HIV, hepatitis B and C, they are all transmitted through injection. Have you or your partner ever exchanged money for sex or drugs? Now coming to risk reduction counseling. CDC recommends client-centered STD HIV prevention counseling, which involves tailoring the discussion to the individual's situation. One example is called Project Respect, which is, I'm going to briefly mention about it. Project Respect was a national study evaluating the efficacy of HIV prevention counseling in changing the high-risk behavior and preventing new sexually transmitted diseases and HIV. It was a large multi-center randomized control trial that compared enhanced counseling, which was 4 sessions, with 2 brief one-on-one counseling interventions based on CDC client-centered approach and 2 brief informational message interventions. This is the didactic, typical current type of practice setting. The results were the trial found that participants in both the enhanced counseling and the brief counseling interventions reported significantly more condom use at 3 months and 6 months post-intervention compared with participants in the regular didactic kind of conferences or counseling. After 6 months, 30% fewer participants in both counseling interventions had new STDs, and after 12 months, 20% fewer participants in both had new STDs. So basically what it means is that one-on-one, more tailored, high-intensity counseling is much more beneficial than counseling in groups in a didactic fashion. This training in client-centered counseling is available through CDC, STD, HIV prevention centers, and I've given the website there, the link. What are the preventive methods? We briefly mentioned about condoms. I'm going to mention the other approaches. Abstinence. Of course, everyone knows about abstinence. Reduction of number of sex partners. Pre-exposure vaccination, male condom, female condom, vaginal diaphragm, spermicides, pre-exposure prophylaxis, and post-exposure prophylaxis. Abstinence and reduction of number of partners. A reliable way to avoid transmission of STDs is to abstain from oral, vaginal, anal sex and be in a long-term mutually monogamous relationship with an uninfected partner. Screening for common STDs before initiating sex with a new partner. I think this is important that we emphasize this particular point to all our clients, that when you start a new relationship, you and your partner go and get tested for everything. You compare notes and make sure you do not have anything. If you do, get treated and then start intercourse or relationship. Now, what about pre-exposure vaccination? There is pre-exposure vaccination for hepatitis B, which is recommended for all adolescents and then at-risk individuals. Hepatitis A for adolescents aged 2 to 18 years of age in areas with existing hepatitis A vaccination programs. Pre-exposure vaccination to HPV. There are two kinds of vaccines that are available in the United States. One is called the Gardasil. A Gardasil is a quadrivalent vaccine for type 6, 11, 16, and 18. This particular vaccine is good for both cervical cancer and genital warts. It is typically recommended for girls between the ages of 9 and 26 years of age. It is recommended for 11 and 12-year-old girls. It is typically recommended, but it can be given between 9 and 26 years of age. It's a 3-dose vaccine at initial visit, then 2 months later, and then 6 months later. So the first vaccine, then first dose, then 2 months later, and then 6 months from the initial visit. There is another vaccine called Cervarix, which is a bivalent vaccine against two types, which is type 16 and 18. This is protective against cervical cancer, but not genital warts. Now coming to condoms, there are several kinds of condoms. Not all condoms are the same. There are latex condoms, there are polyurethane condoms, then there are natural called lambskin condoms, which are made from actually lamb cecum, not skin. Now what are the differences? Latex condoms, when used consistently and correctly, male latex condoms are very highly effective in preventing the sexual transmission of HIV and can reduce the risk for other STDs including chlamydia, gonorrhea, and trichomonas. They might reduce the risk of pelvic inflammatory disease as well. Condom use might reduce the risk of transmission of HSV. The data are limited. The protection that you get against herpes simplex virus with condom use is not as good as that you get for gonorrhea, chlamydia, syphilis, and HIV. Condoms also protect to some extent against HPV-associated diseases. Consistent condom use was associated with a 70% reduction in risk for HPV transmission. Male condoms that are non-latex, which are polyurethane. These polyurethane condoms are very highly effective against STD as well as pregnancy prevention. The effectiveness is same as latex condoms. Now let's talk about natural membrane condoms. These natural membrane condoms, also known as lambskin condoms made from lamb cecum, these condoms have holes or pores that are much bigger than HIV and hepatitis B virus. So these natural membrane condoms are effective against pregnancy, but they're not effective against STD transmission. So it's important that we counsel our clients about not using natural membrane condoms when they are in situations where there is likelihood of STD transmission. Proper use of condoms. Use a new condom with each act of intercourse. Careful handling of condoms. Sharp nails, teeth can break condoms. Put the condom when the penis is erect and before any genital or oral contact takes place. Another important thing is use only water-based lubricants. Oil-based lubricants such as Vaseline, some of these oils, they can damage the condom and increase the risk of HIV and STD transmission. Adequate lubrication is important during sex when you use condoms. Hold the base of the penis to prevent slipping during withdrawal, because if it slips, then some of the ejaculate and semen and seminal fluid can come in contact with the partner, and there is increased risk of transmission of STDs. What about the female condom? Female condom, it's called reality condom, is a lubricated polyurethane sheath. It is a very highly effective condom. It protects against pregnancy, STDs including HIV. It is more expensive, can be used during anal sex also. What about vaginal spermicides? This is one area where we really need to understand and counsel our patients about the risk of using spermicides. Spermicides containing a chemical called nanoxynol 9 are not effective in preventing gonorrhea, chlamydia, or HIV. Frequent use might be associated with an increased risk of HIV transmission. So nanoxynol 9, the vaginal spermicide, is not recommended for STD HIV prevention. What about the diaphragm? On the basis of all the evidence, diaphragm should not be relied on as the sole source of protection against HIV infection. Diaphragm and spermicide use have been associated with an increased risk of bacterial urinary tract infections. And coming back to nanoxynol 9, recent studies indicate that nanoxynol 9 might increase the risk of HIV transmission, because nanoxynol 9 can damage the cells lining the rectum and the vagina, and nanoxynol 9 should not be used as a microbicide or lubricant during anal intercourse. Okay, I have a couple of questions. In regards to Gardasil, what are the recommendations for patients that have missed their second and third dose and it has been longer than 1 year since the first dose? We go ahead and typically we continue, give the second dose and third dose. For the second dose, and then 4 months later, the third dose. There's another question from Margot Deborah Simon. What about squeezing the air out of condom tip to decrease the risk of breakage? I'm not so sure about this. I have heard that when you put the condom on, not to allow a lot of air at the tip, so be careful, but I'm not sure about squeezing to get the air out. As long as you are careful in not damaging the condom, I think it should be okay. There's another comment. I think, thank you for this comprehensive review. One clarification, I believe CDC, SIP, AAP now recommend both male and female adolescents receive HPV vaccine. Yes, correct. Male, FDA has approved HPV vaccination for males also now. Now coming back to the nanoxynol 9, like as I mentioned, nanoxynol 9 should not be used as a microbicide or lubricant during anal intercourse because of the risk of damage to the anal lining, which increases the risk of HIV transmission. Non-barrier methods. Women who use hormonal contraceptives, sterilization, or intrauterine device should be counseled regarding STD protection. Male circumcision. This is a very important aspect of HIV transmission. Male circumcision has been shown to reduce the risk of HIV transmission by 50 to 60% in heterosexual men. Protection against both HPV and herpes. No reduced risk seen in MSM, males having sex with males. What about post-exposure prophylaxis? In case of a sexual assault, hepatitis B vaccination at the time of exposure is recommended, and empirical antimicrobial regimens such as treatment against gonorrhea, chlamydia, and trichomonas. HIV prophylaxis is recommended depending upon the situation of the assault. Emergency contraception to prevent pregnancy from the sexual assault is recommended. I'm going to talk about post-exposure prophylaxis in case of a sexual assault against several infections. Hepatitis B without HBIG given at the time of initial examination. Follow-up doses at 1 to 2 and 4 to 6 months after the first dose. The empiric antimicrobial regimen that we use against possible STDs, or we treat against chlamydia with 1 gram of azithromycin. We treat against gonorrhea with 250 milligrams of ceftriaxone. Some people treat against trichomonas with 2 grams of metronidazole. Emergency contraception should be offered if sexual assault could result in pregnancy. HIV prophylaxis. The risk of acquiring HIV infection during consensual sex. For vaginal intercourse, it is anywhere from 0.1 to 0.2%. For receptive anal sex, it is anywhere from 0.5 to 3%. Oral sex is substantially lower. Risk is increased with trauma, bleeding, the viral load of the ejaculate, presence of genital lesions or STDs in the assailant and the survivor. If HIV exposure has occurred, initiation of post-exposure prophylaxis as soon as possible after the exposure is important. In cases of sexual assault, if the HIV status of the assailant is not known, the HIV risk behavior of the assailant needs to be assessed, such as is he a male having sex with males, crack cocaine use, injection drug use. Factors that increase HIV transmission are whether anal penetration has occurred, whether ejaculation occurred on mucous membranes, whether multiple assailants are involved, whether mucosal lesions are present. If you're going to offer post-exposure prophylaxis against HIV, you consult with a specialist in HIV treatment. If the survivor or the victim appears to be at risk for HIV transmission from the assault, discuss the antiretroviral prophylaxis, including toxicity and lack of proven benefit. Provide enough medication to last until the next return visit. Reevaluate the client 3 to 7 days after initiation of post-exposure prophylaxis. Perform CBC and serum chemistry at baseline. Perform HIV antibody test at original assessment. Repeat at 6 weeks, 3 months, and 6 months. Pre-exposure prophylaxis. Antiretroviral therapy has the potential to impact transmission and acquisition of HIV. In HIV uninfected persons, antiretroviral therapy might reduce susceptibility to infection. A South African study showed that the use of tenofovir gel associated with sexual intercourse significantly reduced the rate of HIV and herpes simplex acquisition by 39% to 51% respectively. What about retesting to detect repeat infections? Retesting several months after a diagnosis of chlamydia or gonorrhea can detect repeat infections. Typically, test of cure after treatment for these infections is not necessary, with the exception of during pregnancy. In other words, if you treat someone for gonorrhea or chlamydia, test of cure in 4 weeks is not necessary. And if you are going to retest them, it is important that you don't retest them within 3 weeks, because the gen probe that we do, it identifies the DNA, and sometimes the dead organisms that are there in the genital secretions can test positive even though the patient has been adequately treated. So if you want to retest for any possible reinfection, you want to wait about 3 weeks. What about partner management? You can give contact cards to the patients to give to their partners so that they can bring the cards with the diagnosis codes, so that we can, when we evaluate them, we can evaluate them for those infections and treat them. Reporting by the providers and labs to the local health departments. If someone is tested positive, the lab informs the local health department about the positive test. And in terms of partner management, patient-delivered therapy via medications or prescriptions given to the clients to be handed over to their partners. This results in a higher likelihood of partner notification and treatment. There was a time when we used to give actual prescriptions and medications to the patients to give it to their partners. Then there was a time when we stopped doing it. I think it's coming back where we are, some clinicians are giving prescriptions to the patients to give it to their partners. Because that way there is a higher likelihood of partners getting treatment, adequate treatment. Now coming to routine STD screening. The United Services Preventive Task Force guidelines say that routine chlamydia and gonorrhea screening for all sexually active women younger than 25 years, even if they are not engaging in high-risk sexual behaviors, is recommended. So everybody younger than 25 years or younger get tested both for gonorrhea and chlamydia. Younger women have a higher risk of gonorrhea and chlamydia infection than older women, because these women and men may have more new sex partners, relative immaturity of their immune system, presence of the columnar epithelium on the ectocervix, which is like a whisk, which increases their likelihood of acquiring infections. What about for older women? The United States Preventive Services Task Force recommends chlamydia, gonorrhea, HIV, and syphilis screening for women who engage in high-risk sexual behavior, such as multiple current partners, a new partner, inconsistent condom use, sex while under the influence of alcohol or drugs, sex in exchange for money or drugs. Routine chlamydia and gonorrhea, syphilis testing for women and men who are in stable monogamous relationships is not recommended. The United States Preventive Services Task Force does not recommend routine STI screening for women 25 years and older who do not engage in high-risk behavior. The USPSTF explicitly recommends against screening asymptomatic women for hepatitis B and herpes simplex virus. Although screening can identify women with these infections, there is no evidence that treating an asymptomatic patient improves long-term health outcomes. Routine STD screening, I'm comparing here what CDC recommends on the left and what the United Services Preventive Services Task Force on the left. CDC recommends chlamydia and gonorrhea screen women younger than 25 years and others at increased risk. For syphilis, screen women at increased risk. HIV, screen all. Hepatitis B, screen women at increased risk and vaccinate. Hepatitis C, screen women at increased risk. Herpes simplex virus, do not screen general population. HPV, do not screen for subclinical infection. United States Preventive Services Task Force recommends chlamydia and gonorrhea screen women younger than 25 years of age and others at increased risk. Syphilis, screen women exposed to syphilis. HIV, screen women at increased risk. Hepatitis B, do not screen general population. Herpes simplex virus, Do not screen general population. HPV, there is insufficient evidence to use as primary screening test for cervical cancer. So for HPV, typically what we do is, for women who have under age 21, we do not test at all. We do not do pap smear under age 21. We start doing pap smear screening at age 21. If pap smear shows atypical squamous cells of undetermined significance, then we test them for HPV. That is called the reflex testing. There is ascus on the pap smear, we do the HPV testing. If there is ascus and the HPV test is negative, we bring them back for a repeat pap smear a year later. If the HPV test is positive and there is no abnormal cells, then we bring them back a year later for the pap smear. But routine HPV testing is not recommended under age 30. It is done only if there is ascus on the pap smear. For women above 30 years of age, along with the pap smear, we do combination tests called pap DNA and HPV test, where we do the pap smear as well as the HPV DNA testing. If both tests are negative, the negative predictive value for cervical cancer is as high as 98 to 99%. And FDA recommends this combination test every 3 years. In other words, if your HPV test is negative, your pap smear is normal, you do not need that combination test for 3 years. And that combination test that is negative is good for 3 years. What about frequency of STD screening? In populations for whom no recommendations exist, screening should be done based on risk factors, local epidemiology, and prevalence of STDs. All individuals tested positive for chlamydia or gonorrhea should be tested in 3 months or any time up to 12 months for reinfections, not for test of cure. Annual screening for STDs is considered for high-risk population. Now I'm going to go over some of the routine STD screening in special groups, such as pregnancy, screening of pregnant women, HIV screening as early as possible, repeat testing before 36 weeks of gestation for high-risk patients. Who are high-risk patients? Women who use illicit drugs, STDs during pregnancy, in other words, someone who had gonorrhea, chlamydia during pregnancy, women who have multiple sex partners, or a partner with HIV. Rapid HIV test for women in labor with undocumented HIV test status is recommended. Serological test for syphilis. Either you do RPR, which is most commonly done, or VDR, which we used to do in the past. It is done early in pregnancy first, and then repeat testing done after 28 weeks of gestation. Infants should not be discharged unless the RPR status of the mother is confirmed. Any woman who delivers a stillborn infant should be tested for syphilis. What about other tests? Hepatitis B surface antigen. Women who are at risk should be vaccinated. We test all pregnant women for gonorrhea and chlamydia at first prenatal visit, and again retesting in the 3rd trimester before the woman delivers, because if there is gonorrhea or chlamydia at the time the mother is in labor, they should be treated. Otherwise, there's a risk of conjunctivitis and pneumonia for the baby. So these 2 infections need to be screened, and the patients need to be treated if they have these infections before labor and delivery. What about hepatitis C? We routinely do not test for hepatitis C. We do it only if it's necessary. Okay, who get tested? Injection drug users, those who have had blood transfusion or organ transplant. What about screening for genital herpes in pregnant women? Women with history of genital herpes, if they have history of genital herpes, you check for lesions in labor. Routine cultures are not necessary. Prophylactic C-section is done only if genital lesions are present at the time of delivery. Acyclovir treatment late in pregnancy reduces the frequency of cesarean sections among women who have recurrent genital herpes outbreaks. Routine antiviral therapy late in pregnancy is not recommended for HSV seropositive women without history of any clinical lesions. Routine HSV-2 serological screening is not recommended for previously undiagnosed women. What about screening for adolescents? Rates of many STDs are the highest among adolescents because they have high risk behavior, multiple partners, unprotected sex, and they're biologically more susceptible to get infections. Adolescents can legally consent to confidential testing and treatment of STDs, including HIV. You don't need parental permission. Careful, non-judgmental, and thorough counseling are particularly vital for adolescents. Advisory Committee for Immunization Practices recommends routine HBV hepatitis B vaccination. Several states consider provision of vaccine similar to treatment of STDs. So no parental consent is necessary for hepatitis B and HPV in some states. What about screening for males having sex with males? Males having sex with males? Okay. Okay, I'm going to look at some of these questions. Ms. Martin, question is regarding HSV screening. Is it true that everyone will be positive for type 1 and can be positive for type 2 even without physical outbreak signs? If type 2 comes back positive in the blood test, it will be diagnosed as a positive HSV? Okay, that's a very, very good question. Herpes simplex type 1 is what we get as cold sores, and as little kids most of us get this. These are cold sores, fever blisters. So many people test positive for herpes simplex 1. HSV2 is what is called the genital herpes. If you test, yes, many individuals can have genital herpes without ever having any kind of outbreak, any lesions. And I think in high risk settings such as where I work, which is Grady Hospital in the inner city, it's an inner city hospital in Atlanta, 50% of our patients test positive for herpes simplex virus type 2. Okay, HSV type 2. If you do antibody testing, more than 50% of the individuals test positive. What it means is that they have been exposed to HSV2 and they have been infected with HSV2. They do not have any outbreaks, but they can pass the virus on to their partners. So they need to be treated not for their outbreak, not because of the infection. They do not have any outbreaks, so then they do not need to be treated for prevention of outbreaks. The only time we treat individuals who are positive for herpes simplex virus type 2 antibody and those who do not have any kind of outbreaks, we treat them if they are involved in a relationship where their partner is negative. In other words, you have an individual who tested positive for genital herpes antibody, never had any outbreaks, but the partner tested negative for the antibody. In order to prevent transmission, we use suppressive therapy on a daily basis. Otherwise, individuals don't need to be treated for being positive for the herpes HSV type 2 antibody. So asymptomatic infections don't need to be treated unless there is a discordant couple where one person is positive, the partner is negative. There's another question. What about PAP negative and HPV positive in women above 30? If a woman, when you do the combination test, that's a good question. When you do the combination test, your PAP smear is negative, but you tested positive for HPV. We repeat the test, the combination test, a year later for them. There's no reason to do any colposcopy or anything. When you repeat the PAP smear a year later, if the PAP smear is negative and HPV is positive, you repeat the PAP smear. But if the PAP smear shows any kind of atypical cells, then you do the colposcopy. Coming back to screening for males having sex with males, routine laboratory screening for these: HIV serology, syphilis serology, urethral infection for gonorrhea and chlamydia, rectal screening for gonorrhea and chlamydia, pharyngeal screening for gonorrhea. Oral chlamydia testing is not necessary. For MSM, for males having sex with males, more frequent STD screening at 3 to 6 month intervals is recommended when they have multiple partners or anonymous partners or sex in conjunction with illicit drug use. Vaccination against hepatitis B and A is recommended for all males having sex with males whose immunization status cannot be documented. If you can, you test them for hepatitis B and A serology, and if they test negative for both, you vaccinate them. Coming to STD screening, every patient seen for evaluation of any particular kind of STD should be screened for all STDs. You have one STD, you might as well be exposed to all STDs. Patients should be informed about the tests that are performed, those that are not routinely performed, such as herpes simplex virus test. STD management: patients should be reassured that treatment will be provided regardless of individual circumstances such as ability to pay, citizenship, immigration status, language spoken, specific sex practices. Now, before go on to the questions, I want to end my conference, this talk, with a case study in a young lady that I saw about a couple of months ago. This young lady was 35 years old, came to Fulton County Health Department. The reason for her visit was she wanted to be screened for all STDs, and she wanted a refill on her valacyclovir prescription, which is Valtrex. She was diagnosed on taking the history. She told me she was diagnosed with genital herpes 9 years ago, and she was given a prescription for Valtrex, and she's been taking it daily ever since. We tested her for everything. Because of her history of genital herpes, in order to confirm the diagnosis, we tested her for genital herpes also through the antibody testing. So I did HSV1 antibody and HSV2 antibody. She came back 2 weeks later for the results, and I sat down and discussed the results with her. She tested negative for genital herpes antibody. So here is someone who's been taking Valtrex daily for the last 9 years, and then she has been abstaining sexually because she did not know how to tell her prospective partner about her HSV infection. She was very embarrassed, and she said, I might as well not have sex and not encounter this embarrassing situation where I have to reveal my herpes infection status to my future partner. So when I told her that her test was negative, she was surprised. She said, Dr. Sarma, I've been told by the doctor that I had herpes, and I went back to this private doctor again and again, and I was told that's what I had, and I was given the prescription. She subsequently lost her job and did not have insurance, so she came to our health department. I said, you know what, if your test is negative, so the chances are very good that you've never been exposed to genital herpes. And I volunteered to retest her, and she agreed to it. We retested her, and her test came back negative again. So oftentimes, as clinicians, this is what we have to keep in mind. We have what is called a clinical diagnosis. Sometimes we think we know what we're seeing. It is true for genital herpes, the clinical diagnosis is very accurate, provided that you know what these lesions look like. For the typical presentation, it's very classic, but sometimes we do encounter women and men who come with folliculitis and other lesions that are not herpetic lesions. And if you make a clinical diagnosis, or you think that's what it is, and in order to make the patient happy, you give prescription, and then that diagnosis gets confirmed over a period of time, or at least the patient thinks that's what that is and continues to take the medication, this is what you end up with. So She was taking a medication that was so expensive for the last 9 years, and when I told her that she did not have it, she cried and cried, but she was relieved. So with this, I will end my talk today, and if you have any questions, comments, I'm happy to entertain. And thank you very much for your attention. Okay, the question from Ms. Simon, from Margot Deborah Simon. What are the recommendations for anal paps for MSM? I am not sure. I don't think it is very clear. Even I work in a Ryan White program. I see only women, but we are not doing pap smears for men because the recommendations are not very clear. So I think it's evolving very fast, but it's not the recommendations as far as I know they're not clear. I'm glad you asked me. Tomorrow I'm going to check and see, but to the best of my knowledge there are no set recommendations. They're being done in some clinics, but how often and all that they're not as clear as the pap smears for the cervix and the vagina. There's a question. I had a heterosexual male ask to be screened for HPV. I do not know of any commercial testing that is available. Do you have any recommendation that I could pass on to this patient and his partner who has had a negative pap and has not been sexually active with the male patient? Male has had several sexual partners and is negative for other STDs. You're absolutely right. There's no recommendation that is given these days for routine testing for HPV for men. It's not there, and we tell them as long as they do not have any HPV like related relations, we don't need to worry about testing them. Another thing is HPV infection is so common. Some experts believe that if you ever had sex in your life, you've been exposed to HPV. Okay. You may test negative, that doesn't mean that it's not there. You can have a subclinical infection, so there's no routine testing that's available. Even for those women who have negative pap smear, see, the only time we do HPV testing is if the pap smear shows ascus for women between 20 and 30 years of age. Just because the pap smear is negative doesn't mean that the HPV is not there. So HPV could be there. That's what I tell women. Your pap smear is negative doesn't mean that the HPV is not there. We're not routinely testing for it. HPV infections are extremely common in adolescents, extremely common in women and men in their 20s, and I think the prevalence rates are like 70% or something like that. So it's an extremely common infection. But there's no routine testing available for men. There's no routine testing available for women either, with the exception of those combination pap and DNA, HPV DNA testing that we do for women about 30 years of age.
Well, I think that may do it for our questions. I don't see any more in the queue. So I'd like to give a very special thanks to our guest tonight, Dr. Sarma. Thank you to our audience for participating in this webinar tonight. Your questions and comments have helped to make this very, very lively and enjoyable. As you may have seen on your announcement, there will be an evaluation that should pop up soon. Please be sure to complete it in its entirety because it's necessary for your CE credit. I also would like to say thank you to our IT person tonight, Mr. Quallen Hare. Thank you very, very much. While I have your attention, I want to give a special invitation to our presentations that will be next week on next Tuesday. I think it's September 6th for any oral health people in the audience. We will have a coffee shop on oral manifestations of infectious diseases. And then please join us next week, Wednesday, for another free CE presentation entitled Small Idea, Big Improvement. And that webinar is designed to teach you some small processes that you can do to increase the flow, the workflow, and other processes in your clinic. So again, this series has been made possible through a partnership. This partnership allows PrimaryCareForAll.org to serve as a resource for you, the clinicians of the National Health Service Corps. Please note that direct financial support for this webinar is made possible through a cooperative agreement from the U.S. Department of Health and Human Services, Health Resources and Services Administration, and the Bureau of Clinician Recruitment and Services. Again, the CE evaluation should be showing in another window or another tab if you're using Firefox. Thank you.